TV now, because they've just developed a whole bunch of new drugs. We are actually not going to discuss those new drugs because they have not yet hit NCLEX, but just so that you know, and I don't even like to do this because then students get confused and say, but you told us. I'm like, yeah, but not that. They're using a lot of monoclonal antibodies for multiple sclerosis with very, very good results. And even though that has not yet hit the NCLEX blueprint, I want you to know that that's what they're doing. So a lot of what we're gonna talk about may not 100% be the way it is so much anymore because there are more treatments out there, but it is what you're gonna be tested on for teach, okay? I really don't mean confusion. All right, so multiple sclerosis is a central nervous system disorder that affects both the brain and the spinal cord. And the symptoms that we see for multiple sclerosis have to do with the demyelinization of the nerves. And the demyelinization of the nerves are central nerves, not peripheral nerves. We just talked about Guillain-Barré being demyelinized peripheral. These are demyelinized central nerves. So regardless of whether they're central or peripheral, when you take away the myelin, what happens to the ability of the nerve to transmit? It decreases, right? Because when it's the myelin that allows it to be nice and smooth, and then to jump the synapse and go to the next one. But what ends up happening is you end up with breaks in the myelin, and over time, depending on the type of MS, you also end up with breaks in the actual nerve, not just the myelin. What happens and how we diagnose this primarily is through sensory and motor deficits. And that again will depend on which nerves are being demyelinated. So if the nerves that work your stomach are getting demyelinated, you're going to have stomach problems. If the nerves that work your hands are getting demyelinated, then we're going to have hand problems. Sometimes they jump around, and sometimes it's the same nerve over and over and over again. And that, again, is going to be told by symptomatology, as well as an MRI. So areas of deficit, that's what I just said. It could be sensory, it could be motor, it could be coordination, depending on where the nerves that are being affected and demyelinated are specifically. So those are all the functions of the brain and the spinal cord. Now, this is what your book says. We're going to put them all together, because the newest theory, which actually is on NCLEX, even though it's not in your book, is that it is a combination of an autoimmune problem, a viral problem, and a genetic problem. It's kind of like you have to have the perfect storm. You have to have a genetic predisposition. Even if there's nobody else in your family, they have shown that there are people that have a genetic predisposition to developing multiple sclerosis. The viral theory, again, is prodromal. Before you get your first symptoms or before the disease becomes active, patients often report some type of viral disease, often an upper respiratory, because they're the most common viral diseases we have. And then the same thing happens that happened with the other myelin, with the Guillain-Barré. The immune system clicks off starts eating away at what is normal tissue, in this case myelin. So the body turns on itself. So even though those are theoretically three separate theories, we put them all together, and it's really now what they believe to be the initiation of an MS diagnosis. So diagnostically, we need to look at presenting signs and symptoms. And sometimes they are very insidious. They're very quiet. And people can sometimes kind of ignore them because they don't really acknowledge them to be a symptom of anything. They're just an annoyance of some sort. So, and some people, on the other hand, are hypervigilant. I had a friend that I worked with years ago, one of my first jobs. And she was the kind of nurse that was very somatic. Do you know what that means? Whatever others people have, they have. She ended up, this will make sense, she ended up being a psych nurse. But when she worked on a GYN oncology floor, she lost her period for 1.5 years. They could find absolutely no reason. There was no reason. She left that floor, she went to work someplace else, and her period came back. She worked on a cardiac unit, and she developed PVCs. Honest to God, put a Holter monitor on her, she had PVCs. She left that floor, she went someplace else, PVCs went away, never to return. Very somatic, okay? So one day she says to me, the inside of my right toe is numb. I said to her, first of all, how do you know that? And second of all, why do you care? Very empathetic, right? Very empathetic nurse friend. And she said to me, I think I have MS. I said to her, I think you're crazy. Now, we were working at the time in nursing education, so we couldn't blame it on anything she was working with. But she said, no, I know it. That was her only symptom, hand to God. And this was a very long time ago, so it was very hard to find a physician who would do an MRI because she said the inside of her right toe was numb. She finally badgered one of the physicians, who was not my favorite physician to start with, to do an MRI. And then I find her crumpled in the corner of a stairwell, because in those days I could climb the stairs. Now I take the elevator. And she's crying. I said, what's the matter? She said, he just called me, I have MS. I said, come on. I said, he quote unquote, he's a jerk. Go find somebody else. She said to me, the MRI was positive. So MRI is the gold standard for diagnostics, but you have to have symptoms to get you to the MRI. Generally more than a numb right toe. The inside part of the right toe, not even the whole right toe, just the inside part of the right toe. But, and through the year, so it was very stressful. It was a very stressful time for her. You know, we were all young, we were just starting to get pregnant, buying houses, blah, blah, blah. She had just put a down payment on a house with stairs. She's sobbing, I'm gonna be in a wheelchair, I'm gonna lose all this money. Her husband also decided he was gonna quit his job and join the FBI. So a lot of things going on, a lot of stress. And she went to Albert Einstein, because she lived in Long Island. She went to Albert Einstein because they had a big MS center, one of the biggest at the time. And the physician looked at her MRI, he said to her, you will never be in a wheelchair. I can tell by looking at where the plaque is and where where the brakes are. He said, you're gonna be fine. And she is. I mean, she went on to be a psych nurse, she got her PhD, she's an administrator in a hospital in Long Island, she has 3 children, they live in a house with stairs. So it all worked out, But at that moment, you know, you think your world is collapsing. And that's kind of what happened. So, history and physical, we really need to listen to patients even when we think they're being ridiculous. And you should probably not say things like I said to her, because that's not therapeutic at all. Like if I wrote that on a process recording, it would be non-therapeutic. Right? Bad, non-therapeutic. So, presenting signs and symptoms can be any neurological sign or symptom. It can be a loss of vision, a loss of smell, a change in smell, a change in vision, paresthesias, numbness. It could be periodic loss of function. And then it goes away, because in the beginning, until the myelin and the nerve are completely destroyed, it comes and goes, which is the other thing about MS. The more typical type, or the more common type, is relapsing remitting, which we're going to talk about in a minute. So you have periods of relapse, and then you have periods where you're perfectly fine and healthy and you do well, and you have no symptoms at all, and then you relapse again. They will do a lumbar puncture, again, looking for other things. It will show increased protein because the myelin is being destroyed. They will do MRI. They might do a CAT scan first, only because some insurances require a CAT scan before they'll do an MRI. But MRI is the diagnostic tool for MS. They may do muscle testing to see if it's an actual muscle problem. And when you look at the blood work, you can see none of it is really specific, right? Increased sed rate. What does that tell us? What does it tell us? It says inflammation. That's the only thing that tells us. That somewhere in our body there is inflammation. It doesn't tell us anything else, so not terribly useful. Increased gamma globulin. Again, inflammation, infection. Increased white blood cell. Same thing. Increased protein is the only one, but that could mean a whole lot of other things. It doesn't necessarily mean MS. But it does kind of kick off if you have neurological symptoms and you have an increased protein that something is cooking. Okay, so we already talked about the insidious onset. Just think of the inside right toe. Remissions and exacerbations. I just said that this, the classic, I guess that's a good word for it. The classic MS is remissions and exacerbations. The exacerbations last a couple of weeks, and the remissions can sometimes last months. It is more common in females, and generally between, it says the second and fourth decade, basically your 20s to your 40s. So right in the middle of getting your life together, you get diagnosed with a problem that could, well, runs the risk of changing your life. So it can be very stressful. They may need emotional support or psychological support or any one of those other things. Sometimes with degenerative diseases or diseases that have multiple stages, not everyone does well in a group, especially if it's a mixed group, and we talk about support, because you see yourself in 5 years and somebody else in the group. Sometimes that's why, in some instances, they'll do a group, let's say, with early stage MS or newly diagnosed, and then they'll do one that's for patients that have later disease, breast cancer. They'll do one for early stage breast cancer, and then they'll do one for people with metastatic breast cancer. Because when you're in early stage breast cancer, you don't want to see a patient with metastatic breast cancer sitting there looking at you and thinking, that's my future. So just to be careful about some of those kinds of things. All right, so there are some different classifications. There are some different classifications for multiple sclerosis, which I probably should use my notes for, which I can't seem to find. Let's see. Not there tonight. We'll wing it. If I forget something, I'll find them eventually and I'll let you know. So benign multiple sclerosis means that the patient does have symptomatology. They do have spots on their MRI that show demyelinization, but that it is never going to progress. It is just going to be episodic, and they may have years in between where they have no symptoms at all.
You said it will only be episodic?
No, it can be episodic, not definitively,
Okay.
okay? In relapsing remitting, that's the kind that is more traditional, for lack of a better word, more classic. And what happens in relapsing remitting is you have periods of time where you are well. That's the remission piece. And that can be for months and months at a time. If you are in remission for a year, you're considered to have stable disease. But then there are periods of exacerbation. And periods of exacerbation are when you are symptomatic. And the symptoms generally last for about a week or two where they are acute. And then they take 2 to 4 weeks to subside and go down to nothing. And again, those symptoms are going to depend on where the nerves are demyelinized. So for my friend that I was talking about, besides the toe was for a while. That was like her only symptom. And then she actually she had on her face, where her face, one side of her face was paralyzed, so she had drooping on her face. Her eye drooped, she had no change in her vision, but then for a year, that was the symptom that she would get when she went into an exacerbation. Then she was fine, she was in stable disease for a couple of years, and then the next thing that popped up was her back. She had numbness and tingling across her entire back of the like where her scapula was down to like mid-back. So that was, for about 2 years, that was the symptom that she had. And then again, she was stable for a couple of years with no symptoms. So for her, it was very back and forth. It's not that way for everybody, but it was that way for her. For some people with relapsing remitting, they get the symptoms exactly in the same place all the time. That's actually a little more dangerous in terms of long-term, because that means that that same nerve is getting attacked each and every time. So the possibility of permanent damage is higher. Generally speaking though, the relapsing remitting, the patient is not going to have is not going to have interference with their ADLs to a point where they're going to need assistance. They're going to stay functional for probably the rest of their lives. That being said, there are a percentage of patients with relapsing remitting, about 50%. About 50% of people with relapsing remitting will convert to secondary progressive. I know it did that. Okay, so So secondary progressive is when you get progressive disease after you have had relapsing remitting. And progressive disease means that you have more periods of time where there are exacerbations and the progression of the deficit continues. And for some people, this is slow over years, and for some people, this is quickly over 1 year. Primary progressive is when you have a type of MS. Right from the beginning, it is fully progressive. You have very few remission, exacerbation, remission, exacerbation. You just have progression of symptoms in a downward fashion. So those people are gonna be less functional in a shorter period of time because they have none of the remission periods where the body is just resting, okay? So those are the 4 types of MS. And if you notice, like on the commercials, when they talk about it, most of the drugs that they're coming up with, most of the monoclonal antibodies are for relapsing remitting. So we already kind of talked about all of these. Presenting signs and symptoms, the visual disturbances, numbness and tingling, spastic muscles, motor weakness, slurred speech. Again, that slurred speech is because of the motor part of speech, not the intellectual part. Fatigue, tremors, bladder dysfunction, and overall sensory and motor dysfunction. Because we can't really tell exactly what's gonna be affected based on what nerve it is. These are the exacerbation factors. Exacerbation factors for patients with remitting, relapsing remitting are probably the most important things. Because these are your teaching points on helping them to manage their lives, to decrease the number of exacerbations they have, in addition to taking their meds. So when a patient has MS and they're excessively fatigued, like when my friend was doing her PhD and staying up all night to write her thesis, she had more exacerbations than when she was on a regular schedule and sleeping enough and doing all that kind of stuff. Same thing with the poor nutritional and fluid intake, it was the same thing. So she probably had a double win. She wasn't eating, and she was up all night because she was trying to finish. It was a tough year. Any exposure to infection, because why? It's gonna ramp up the immune system again, and it's gonna get all of those IgMs and IgGs all excited, and they're going to eat more of the myelin away. Any emotional stress, same thing. Drug reactions, not talking about street drugs, although those aren't good either. We're talking about drugs that they are allergic to or have a reaction to because they didn't know they were allergic to it. Because what does that do? Ramps up the immune system. And then environmental temperatures. For patients with MS, they have a tendency to get overheated, and when they get overheated, their muscles don't work as well. So they need to be super careful about the environmental temperatures that they are exposed to. The other interesting thing about MS is that you have more cases of MS in temperate zones and not as many in very cold and very warm. But more, across the globe, temperate zones have a higher incidence. So temperature does seem to have something to do with something, although they don't know what it is. she ran relatively short distances because she couldn't make longer distances. But she would get to the finish line and literally collapse, her legs would just go out from under her. And then they would have cooling blankets to cool her down and bring down her temperature, and then she would be better. I was thinking, why would she run? But apparently, she liked it. It was like one of those nice interest stories on TV. So acute care problems for patients with MS, again, all related to wherever the nerve is that is involved, but some of the more common and the more problematic are chronic urinary tract infections, respiratory tract infections because they may not get the innervation to the lungs that they need, to the diaphragm, because how is the diaphragm innervated, do you remember? From one of the spinal nerves, up around C3, C5. Adverse medication reactions, we just talked about. And that's problematic for people who don't know what they're allergic to or develop an allergy after taking something for years. I have a friend who, his whole life took penicillins, and he tended to get strep, still gets strep. He's like a grown man with strep. And he called me one night and he said to me, I got this weird rash. I went over where I wrote. I said, are you on antibiotics? He said, yeah. I said, you're allergic. He said, don't be ridiculous, I take this all the time. I said, doesn't matter, we can always develop an allergy. Allergies can be either immediate, that you're like from birth, you're allergic, or because of overexposure, you can become allergic. And yes, they did skin tests, and yes, he was allergic. So adverse medication reaction, so knowing what you're allergic to and what you're sensitive to. Psychosocial alterations, this changes your life in some ways. Even if it doesn't change your life, like my friend who still had her house and her children, it changes your head, it changes how you cope and what you think about, and do you have that baby that you wanted, or is it gonna cause so much stress that I'm gonna have an exacerbation that's not gonna go away? Do I buy the house? Do I believe this guy who says to me, yep, no, that MRI is fine. You're gonna be fine, you're not gonna be in a wheelchair. So it creates emotional stress and psychological stress as well. And then for patients who have more and more immobility, all of the problems of immobility, and we know that immobility causes problems with every single system in our body, right? So as the patient progresses in their disease, if they have that type of disease that's gonna progress to where they're immobile, we have to worry about the complications of immobility. We took care of a patient a couple of years ago, and she was all contracted. She weighed, I think, 84 pounds. She was 44, and her mother had been taking care of her at home because she didn't want her in an institution. She progressed very rapidly, and now she was, like, you couldn't even move her to wash her. She had pressure ulcers all on this side of her body because her mother said, well, she doesn't like the other side, so I never put her there. This is where she's comfortable. The downside of families taking care of family members, they don't want to hurt them, they don't want to upset them. So she was a total mess. She had pneumonia, she had infected pressure ulcers, she had a Foley catheter, she had contracted muscles. She was 46. Her life could have, she wasn't gonna get up and walk, but her life could have been different had she been cared for in a different manner. And I'm not blaming the mother, I'm just saying that we need to do a better job of teaching and helping them. If we could have taken a picture of her and we could have put it in a book and said complications of immobility. Okay, so interventions, physical therapy, early and often, not so often, but making sure that they stay in good physical condition so that it will help if they have less and less function, if they are in better condition to begin with. So they don't have to go to a physical therapist every day, but they could go get some exercise, and if they're good, like some people, they can continue them on their own at home. They may at some point need occupational therapy. You know occupational therapy does what? Helps with ADL, so it provides, occupational therapists provide tools to help with ADLs if you have some dysfunction. So if they have difficulty with their hands and they can't close their fingers around a fork anymore, they make those ergonomically really thick forks that they can use. Things like that. Although I did have to laugh when my mother had fallen, the downfall of all the older adults, right? My mom had fallen and had a small head injury, and they sent her home and she was fine and it absorbed and blah, blah, blah. And in came the occupational therapist and she hands my mother one of those things, so, because my mother was one of those people, where she was like 4'10". She shrunk. She started at 5 foot and then she ended at 5'9" maybe. But she gave one of those things to like get cans out of the closet. I couldn't squeeze, and I've got good hand strength. I could not squeeze that little handle. And I said to her, could you take that away? Because she's gonna end up with the can on her head. Because she couldn't grab it for the pinchers to close. That was a disaster. She goes, oh no, it'll loosen up. I was like, oh no, take it away. Psychosocial support, but what this is going to mean, again, we already talked about that. What kind of group? Do they want a group? Do they not want a group? Do they want to, would they rather have a private person? Would they rather just talk to their friends and have coffee? I don't know. But we need to offer it. Pharmacological agents that are used are steroids, antispasmodics. Interferon is a protein that is normally made by the body as part of the immune system. And actually, they now use interferon A and B. I forgot to put that up there. The downside to interferons is that they make the patient feel like they have the flu all the time. So patients really hate taking them because they just make them feel yucky. They can give them immunosuppressants, but they come with their own problems. They can give anticholinergics if one of the nerves that is involved is involved in tearing or salivation and things like that. They can do anticholinergics. And leteromir is an antiviral. That button, that bullet should be like over under it. And even though this is not a viral injury or a viral disease, they have found that for some reason, some antivirals, this one in particular, the leteromir, will help to decrease the number of exacerbations the patient has. They don't know how it actually works. Okay, chronic needs, rest, nutritional intake, stress reduction, exercise, psychosocial support, staying on their medication regimen, preventions of hazards of immobility, and then the last one that nobody ever wants to talk about, sexuality. We are very uncomfortable with that word. We all do it, we all like it, and yet we don't like to talk about it. And we can't ignore that part of a patient. I'm not saying you need to be, I don't even know, who does sex ed these days? And don't tell me Dr. Oz, because I will shoot myself. There used to be 2 women urologists that were, one was a urologist, they were sisters. One was a urologist, one was a sex therapist. They were very popular for a while, but whatever. Sexuality and actual sex is part of what makes us human. It's part of our humanity is to want intimacy with our partner, whoever that partner may be. And when you're 30 years old and you have a chronic illness, sometimes you don't always feel as sexy, number 1. You don't feel like having sex, number 2. Or you can't because of the nerves involved. Not that you can't, well, maybe you can. But either you can't or it's not comfortable anymore to have sex. You do not have to be the person who fixes this or attempts to fix this. But you do have to be the person that at some point says, are you okay with your sex life? Do you want to talk to somebody? And then you better find somebody, then you gotta find them. But you really we need to talk about this, because it's one of, I don't know, intimacy to me is one of the things that separates us from animals. And we can't put it aside because the patient is sick. They don't put it aside. I mean, think about the story I told you that I read in the book yesterday, how she hadn't seen her husband naked, how they had, clearly if they hadn't seen each other naked, they weren't having sex, they weren't in the same bed. Because if he was that skinny and that uncomfortable, they weren't doing it on the floor. That would make it even worse. So, and she longed for it, and he probably did too. But we tend to not address it because we are uncomfortable with it. And you don't have to walk in and say, hi, good morning, my name is Tony, I'm your nurse today, can you tell me about your sex life? No, that would not be appropriate even. But once you're talking to a patient, or even if you're doing an admission history, sometimes that actually makes it even easier. You can say to them, how are you doing with your intimacy with your partner? I'm not crying, I wanna know because I want to not ignore that part of who you are. You would not believe what people will tell you if you give them just 1 minute. Sometimes it's like la 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 la, and you don't wanna hear it, but now you've opened the door, so now you gotta listen. And then you can say, you know what, I really don't know a lot about that, and I don't know how I can help you, but I'm gonna find you somebody who will, and then find them. Damn it, find them. Simple things. You know, we used to take care, for some reason, we had one summer where we had a rash, and I mean, we had about probably 8 or 10 young men with testicular cancer. I had just started this new job, and of course, being me, first thing I say to the nurses that I'm working with, okay, where's the information on sperm banking? They're like, what? It's like, what do you mean, what? I said, he's 22. He needs to talk about this. We don't have that information. By the Monday of the next week, I had found a sperm bank, I had the forms in the office, and I had an education sheet for the patient. Then I had a mother say to me, because one of them, the girlfriend came. She was like, I'll take that. It's mine. Because sometimes when you're 22, you're not really thinking there. Sometimes girls are because they have less time than boys, but when you're 22, you're not always thinking that far ahead. But you have to at least know, and you have to at least prepare. And with something like MS, they need to know that the stress of that pregnancy, if it's a girl, may cause an exacerbation. And what are we going to do, and what can we do to mitigate that? Do you still want to think about children? Do you want to think about adoption? If it's a guy, if it's the nerves that are involved in the penis, then it may be a problem. So we have to address these things, and we have to get comfortable at least starting the conversation. The guys with the testicular cancer, I think all but one sperm banked that summer. There were 8 of them, 8 or 10. And all of them did it. Once they had the information, and two of them didn't, because one had already received chemo, and you can't do it once you start. But the other one was like, nope, I'm not doing that. I'm like, okay, that's your choice. One, the mother kept telling me he doesn't want to see that. And the kid was behind her back saying. So I waited till mommy left. And so we sat down, we had a chat. He was like the eyes behind her. If you don't ask, you don't know. They don't have to say yes. But once you explain that, you may never have another opportunity if you don't do this for your own children. And if they say that's okay, then it's a choice they make, and it's okay. That's all. but we can't ignore their sexuality. It doesn't do us any good, certainly doesn't do them any good. We'll talk about sexuality with spinal cord injuries too, just in case you thought you were done with it. I'll make you uncomfortable one more time, maybe twice. The educational needs of patients, how to use their medications. Some of the interferons are sub-Q, so they're gonna have to be taught how to give it sub-Q, those kinds of things. Making sure their fluid intake is good, spacing activities so that their muscles don't get overtired. Their emotional reactions, validating them and letting them know that they're okay and that they're normal. Skin inspection and pressure ulcer prevention, that's for the patient, not just for you. We need to teach patients and patients' families how to look at their skin critically so that they don't get pressure ulcers. You know, you guys scoot around in your chair, I move, I change legs, I sit down, I get up. It's all because of pressure in the area, and we know we've gotta move. Sometimes they don't know that. If that area is the area that's numb, they're not gonna know. The avoidance of temperature extremes, we already talked about. What community resources are out there. Range of motion to maintain, what does range of motion do only? Joints, does nothing for muscles. The only thing it does is keep a joint moving. Balanced diet, and then safety, depending on where and how their exacerbations are presented. You know, they may shuffle along. If they're shuffling along, they probably shouldn't have throw rugs in the house. And then priority nursing diagnoses, disturbed body image, disuse syndrome, again. Ineffective protection, that has to do with the immune system, risk for infection, and then role disturbance. How is this going to affect their role in their family and their life and their, okay, I'm just gonna quickly do those overheads that I said I was gonna do that I didn't do. And then you'll be free as birds for the weekend. Kinda hard to say, hold on. I'm taking you for a blast from the past. This is an old paper chart.